Right, we shall start. So, Dr. Neeraj?
And Dr. Neeraj is talking about Universal Integrated Electronic Eye Drop Sleeve, a novel compliance monitoring system for glaucoma patients. Dr. Neeraj.
Thank you. I was the first speaker in the last AIOS also. So this is,
Lucky for you.
yeah. Just pause one
You get a
second.
purple cap for if it's a hat trick.
Can we, yeah. So good morning. I'm going to talk on Universal Smart Integrated Bluetooth. Yeah. So can we have the video? It's a video presentation, which is a Bluetooth eye drop for glaucoma patients and other specialties. Can we start the video and the timer? Video, please. With the
We all
volume.
know that glaucoma is the second most common cause of blindness worldwide. Topical medications are gold standard for treatment of glaucoma. Literature suggests that up to 50% of patients are non-compliant in glaucoma medication. This further leads to progression of the disease. Smart Bluetooth enabled devices have taken over the world, and it is when we had a research question to incorporate Bluetooth technology into eye care. Thus, we innovated the world's first smart Bluetooth enabled eye drop sleeve, which is a novel innovation combining eye drops and the Bluetooth mobile technology. Components of auto drops include a battery pack, a USB-C port charging device, a microprocessor unit, a motion sensor, and a sleeve with a squeeze sensor. Overall, the device looks like this when combined. Any eye drop of patient's choice can be clipped onto the eye drop sleeve. The USB-C port is used to charge the Bluetooth sleeve. It has a battery life of 20 days when charged for 3 hours. This further comes with a drop guider to make sure that the eye drop actually falls into the patient's eye. The beauty of this device is that as soon as you tilt the sleeve and squeeze the sleeve, and as soon as a drop is instilled, the mobile application that it is connected to via Bluetooth will document the exact time and the number of drops instilled. This is an application with an alarm-based system which does not go off unless and until you actually manually switch off the alarm. Once the alarm is turned off, the patient then takes the entire setup and actually makes sure to put the drop guider on the eye drop sleeve. The drop is then instilled by the patient in his eye. As soon as the drop is instilled in his eye, there is a record that is saved on the mobile application with the number of drops, time, and the date of installation of the eye drop. The mobile application has a very simple user interface with the name of the drop, the time, the date, and number of times that it has to be put in the patient's eye. Not only this, but you can actually select different ringtones for different sleeves or eye drops to be instilled. On the other hand, every time the patient is instilling the eye drop, an automatic CSV file is created in Excel format that can be seen by the surgeon on any visit. This will be emailed to the surgeon timely to make sure that he comes to know about the compliance of the patient.
We are also very happy to get a funding from His Highness, and now we are coming up with a marketed product which will come in the month of September. Thank you. this is how the final product is now going to look like. So I have the 3D printed prototype over here, which is a fully functional prototype. His Highness has now tied up with us, given us a funding. They've come up with a final product, which they will be selling along with their glaucoma eye drops, free of cost. So one sleeve in a pack, which will be given to every patient who buys the glaucoma eye drop first time. And that sleeve can be used for multiple drops. So no cost for the patient. That's the MOU signed with His Highness.
Yeah, but then you should ensure it goes to other companies too, no? You need a
So-
larger footprint.
So at present, because they have given us a funding,
Yeah.
I can also tell the amount. It is a funding of 10 lakh rupees. We have got it from them, and we have already started work, like you saw the final product. Further, there is also a clause which mentions that we can also give it out to other companies also, of course, with the help of His Highness Ophthalmics.
Very nice. Very nice.
Not only glaucoma, but even other diseases like dry eye, cataract. You know,
Yeah.
it can be used for.
Wastage of drops will be
Yes, so
prevented.
you come to know how many drops, exact number of drops, exact time, if the patient has missed the drops. Everything is, there are two interfaces. One goes to the surgeon via email, a CSV file. So every time you squeeze the drop, the mobile application has two phases. One is the patient interface and one is the doctor interface. Patient relative can see at night if the relative of the patient is coming home and saying my mother has not put the drop. So he can see, and the surgeon automatically gets an email every time the patient has put the drop. Obviously, surgeon doesn't have time to see all the drops, but he can come to know how much is the compliance.
Compliance. Very
Further, we'll also integrate percentage. So we'll give a pie chart where the surgeon can see.
The backend is what, progressive web application, or is it written, coded in a
I-
lower language?
No, so it is a proper UI based application which is being again made by a IIM and a IIT based person who stays in Hong Kong. So he is IIM plus IIT and he is working on it. We have hired him and he's the one making a proper application, which is going to be one application for the patient and the doctor both. But unfortunately, what we have also done is that because no surgeon would want to download an application, we've also added a email. So
Yeah, so that was the catch, you know.
Yes.
I
You don't
think,
want anything
I
installed
think
on
we
your
should
system,
go on
so
to our
yeah.
next speaker. Thank you very much.
Thank you so much.
And this certificate, I would ask Dr. Ellen Kumaran to hand over the certificate. Wonderful talk, wonderful talk. We go on to our next speaker, Dr. Anahita Shroff. Oh yes, Dr. Prasanna Venkatesh. Sorry. Dr. Prasanna is going to be talking on bringing perimetry to life. No, Prasanna Venkatesh.
Yeah,
Yeah.
89.
Yeah. You make it 4 minutes, please.
Thank you once again for this opportunity.
It's
Can
4.
I have
It should be 4, not 5. 4.
yeah,
Yes. Yeah. Start.
ma'am, the view is not correct here. Yeah, so I'm going to share going into basic science, a very much needed innovation to grasp real visual field loss. So animative perimetry is something, as you can see this two-dimensional cone here, and when you see it on top, this is how it looks, right, in our 2D printed. But visual fields is actually a three-dimensional graphic representation, and how does it really look? So this is my animation grid module that I made to show the points of all the points that we are going to test. And then does it really look like this, real differential light sensitivity? In the macula, if you see, you'll be able to see the dim light that the macula is sensing. Slightly away from the macula, you'll be able to see a much brighter light. That is why the values are, lesser when you move away from the macula. And when you move more to the periphery, it will look even more brighter. So this is where the numerical grid that you can see the numbers, right? 30, 31, and in the periphery it's 22, 27. So this is an animation module that I made where, for example, to evaluate a scotoma, what is a relative scotoma? You can see the weaker stimulus is seen, but it's not seen, but a brighter stimulus is seen. Absolute scotoma, localized defects, and this is a differential light sensitivity. And I'm also going to show you some 3D printed modules of these innovations that has been made, isopter contraction. So in normal, if you see, the macula is not able to see the dim light which was perceiving once, but now it is only able to see a much brighter light. Similarly, on the paramacular regions also, if you see, the dimmer light which was perceived once is not able to be perceived. So it's a teaching module which helps you in understanding the cognition of an isopter contraction, and even for kinetic perimetries, like how the isopters really contract. You can see the stimulus 1E, 2E, which is now not there in the isopter contraction because it gets shrunken, right? The small stimulus are now not being able to see. And then the real-time grayscale pictures that you see, this is the animation showing the 30-2, how 6 degrees apart they are, and how 3 degrees apart they are from the horizontal, and the -2 meaning that they are just 6 degrees apart. And 24-2, all the peripheral points are removed. And then in the 10-2, in 24-2 strategy, you are able to see 12 points, whereas in 10-2, you are able to see 68 points. So this is a teaching animative module that has been made along with testing strategies, the CETA that we see, the staircase algorithm. So in the staircase algorithm, what happens, my dear friends, you see the black arrow, 4 decibel gets incremented, and then you come back 2 decibels. So for example, if this is the seeing area of the patient, the yellow arrow that I am showing, see how the machine operates. First, it shows you this point, that is the brightest stimulus. It reduces 4 decibels, it reduces another 4 decibels. Now it reduces 4 decibels, the patient is not able to see because his foveal threshold is now altered. Now it goes back another 2 decibels, and there the patient is able to click and is able to understand. This is the fine tuning of the staircase algorithm. Let us see how it happens in a real time. Only one point is taken, decibels are reducing, reducing, not able to see. A 2 decibel is increased and is able to see. So this is an animative grid where all the strategies are made. Along with the animations, I have also made a 3D printing module which I am going to show demonstration, where this is the last part of it, where I have 3D printed the visual fields, because you get to understand the scotomas much better. What is an isopter contraction? What is a real 3D visual fields? And last but not least, for the patient, what is actually expected from the patient? From a student's point of view to a patient, how does he see the points? His eyes are occluded. So what is the fixation target videos that he see? And finally, if you see this video here, so this is a video showing how the patient actually perceives the point. So once he takes this video, he'll be in a real world for better demonstration of the visual field. Thank you once again for this opportunity.
Thank you. Thanks for sticking so much into. Yeah.
So 3D functional analysis is something that we are thinking in a 2-dimensional plane, because we see this from a top angle. So basically, can we island of vision in a hill of darkness, if we are able to print it, and this is an arcuate scotoma that you can see. The idea is, if the scotoma is steeping very acutely, or is it steeping very slowly? So 33, 27, 25, or is it from 33, it is immediately dropping to 0. Like an NTG where the fixation is steeper, deeper and more closer. This scotoma is more of a sloping scotoma, whereas in NTG you will immediately drop down. So this gives us an idea of how the 3-dimensional functional visual field is remaining. We are all used to see this isopter contraction in the book, where you get a one hill and another hill is shallow. But what it really signifies is, if 33 is moving to 22 at periphery, it starts with 27 and slowly decreases. The whole points are coming down. So this 3-dimensional representation will give us pedagogically a better view on how to interpret the visual fields, and also to the patient who's going to take it, if we are able to show a video of how the points are, how the cross-section target, because in literature there was no animative teaching module or videos for the patient. So that's why we made this, and thank you, ma'am.
Santosh.
Nice innovation. How we can use it in our daily practice?
So one is 2 components, sir. For the students or for teaching, that is a one component where you can actually show them each points, because each grid has been now animated, and the staircase algorithm, or how the visual field points happens in a clover leaf, and then it slowly demonstrates. So basically we don't get to do, either we do the visual field and then we know how the machine operates, or we need to make pedagogical teaching videos like this, which will accelerate learning for the fellows or the students, because they should know what to expect from the machine. And second thing is the patient, sir. If the patient learning curve is a very, very big hindrance, if you make an animative video of once he sits, what is the target he is going to see, where and all the points will come, what will be the stimuli sizes or the intensity. So once he sees those videos, he is now understanding how to go about it, because now when he places his chin, he'll be able to know how he should go, and the learning curve is able to accelerate, and this teaching will help us accelerate the patient's output also, because visual field is somewhat a demanding task as of today. So that is where I see this video based teaching module will help the students and the patients as well, because they know what to expect from the machine when they are put on to the machine. Yes, sir.
Thank you.
According to an illiterate patient will be more comfortable with automated perimetry after going through these classes.
Yes, sir. This is more like a pre-counseling of the visual fields rather than putting him into the machine and he is completely unaware, and then we depend on the funders or OCT. We have this module and put him into the machine, sir. Yeah, him or her.
Yeah.
Sir, as of now, it is a visual language that we have created, but it is definitely capable of putting it in under any regional language, because the video-based
Anahita?
animations are all visually depictive rather than languages, sir. It's like they go in, keep their chin, then the points start appearing. So it's as if an immersive experience of what he can actually expect. Language should not be a barrier, sir. Yeah.
Thanks, Prasanna.
Thank you, ma'am.
Thank you
And the
very
videos
much.
are all open access, which are available on YouTube as well as other platforms. Yeah.
So we shall go on to our next speaker, Dr. Anahita Shroff. Get ready. You have 4 minutes, and her talk is on Insight VR IOL Stimulator. Oh, sir. Yes, yes. Dr. Santosh. Yes.
This is not mine. Second one. This is not mine.
Who will ask the question? He will ask the next question.
That's Anahita, na?
Yeah, that's Anahita.
Okay, so it's Insight VR IOL Simulator,
This one.
experiencing the future.
What happened?
They display, they started showing workings.
Can you reset the time?
Reset the time, yes.
Reset the time, please.
Should get 4 minutes.
What happened?
Yeah. The next speaker is going to be Dr. Ashwini Kumar. We'll have to present on this board.
All the advanced cataract, in spite of all.
Good morning. This is Dr. Anahita Shroff. Today I'll be presenting my innovation, Insight.
Cataract, in spite of all.
And there's some glitch with the
It's
thing.
looping, yeah, please.
So there's some glitch. It's not playing.
Cataract, in spite of all.
No, it's looping, yeah.
Should we?
Can you mute the voice and can you talk?
Yeah. But sir, the video is playing quite slow. It's playing at half speed.
Okay, we'll go at it once more. Otherwise,
We'll go on to our
we'll
next
break on to
speaker
the
and
next
get
one.
to
and then come-
Cataract.
Ma'am, you can go on to the next one. It's going very slow.
Okay.
when it is-
Okay. Dr. Ashwini Kumar, are you ready?
Do you have it on your laptop?
Yeah.
Okay, it's okay. So
The next
You
speaker
connect the
is
laptop.
Dr. Anamika.
audio visual, please connect the laptop on the other side. So we have the next speaker.
After Ashwin Kumar, Anamika. You all have to be on the podium even by the time the other speaker is finishing. So after Anamika is Neha. Yes, yes, Ashwin Kumar. Dr. Ashwin Kumar will be talking on visual rehabilitation, a hope in a hopeless condition of eye conditions. And you will be taking his question. He's already asked. Doctor.
खड़े हो जाएंगे आप मैं फोटो खींचूं
No, you haven't asked the question, no? He will ask. No, he will ask the next question. He will ask.
Please change the slide.
Yeah, doctor. Yeah, the next speaker, Anamika, be here. Dr. Ashwin, could you start?
Yes, sir. Apple tree.
सर आपने PPT दे दिया
हाँ दे दिया सर. Apple tree.
Yeah.
हमने देखा भी था.
डॉक्टर
No, but the speaker is Ashwini Kumar first.
Yes, I am Dr. Ashwin. Can we start?
Yes.
I am Dr. Ashwini from Mahavir Netale, Patna. I was a surgeon before, but a brain hemorrhage made me paralyzed. So I have started new treatment of visual rehabilitation. So I did a study of 55 low vision patients. At that time it was very less. So there were just 55 patients. I took the consent, it was in the month of November. No invasive technique was used. Its majority of patients were from poor socioeconomic status. इसको change करें कोई? Most of the patients were from poor socioeconomic status. As the Mahavir Netale Vyarvak is a charitable organization, so I did a study on the low vision aid patients who couldn't see well with any kind of vision. भैया थोड़ा सा हेल्प कर देना प्लीज. स्लाइड में से मदद कर दीजिएगा. स्लाइड में भैया, स्लाइड में इनको फर्स्ट स्लाइड कैसे आएगी? क्या आप कैन यू हेल्प शुरू से? हाँ, अब इसको नेक्स्ट कीजिए. नेक्स्ट वाइल सब नेक्स्ट. The visual active patient were overwhelmingly poor and were half or less than 660 vision. They all complained of inability to perform daily tasks and unable to benefit from surgery, medication or any spectacles. Next. So all subjects reported difficulty in performing common household tasks. However, it was surprising that a majority of complained about inability to view mobile and research television and other things. Next. So the researcher, me, used a variety of household articles because they couldn't afford the expensive magnifiers and all. So it is signature guide to make signatures. So this is Notex to make the signatures. Next. So, and I found these two very interesting tools at Akhand Jyoti Eye Hospital, Chhapra, where they used a special box to view the color vision of the patient, and this is Paley Robson chart for the contrast sensitivity chart. Next. You can see that the patient satisfaction rated along, a majority of them were high. The researcher concluded that using practical methods and simple household articles like torchlight, needle threader and signature guide, the patient can see well. Next. Thank you so much.
Thank
I
you.
need your
Thank
blessing
you.
for the future.
Thank you, Dr. Ashwini.
चलिए भैया.
Dr. Ashwini, what is the cost involved?
जी?
Cost?
Sir, I am a consultant ophthalmologist and visual rehabilitation specialist at Mahavir Netale.
Is free of cost to the patient?
नहीं मैम, सर महावीर मंदिर में जो भी चढ़ता है वहाँ पे पैसे आते हैं उनसे रन होता है. This is charitable organization.
Okay.
So
Anna.
I work there, sir.
Right.
And
Thank
lots
you.
of patients get benefited from this.
Okay.
Because
Thank you.
They couldn't afford.
Thank you very much.
जी. आ रहे भैया.
We go on to
Photo-
our, the timer
ले
could be
लो.
set for the next
आप ले लो
speaker.
भैया, आप ले लो. वो ले लो, उनको ले लो.
Dr. Anamika Paul. She is going to be talking
सीधा कर
on
भैया,
Perkins
सीधा कर,
application
सीधा
and ergonomic approach.
timer
And he has to ask question. They have asked. So he'll ask.
Hello everyone, good morning. I'll start.
Next speaker is Dr. Neha. And after Neha, it's Vignesh. Yes, you get started. Sorry.
Good morning everyone, I'm Dr. Anamika. I'll be taking you through a journey of Perkins application and how it can be used in an ergonomic approach. So IOP plays a very important role in glaucoma. The IOP measurement has evolved since century. It started with digital palpation, then Sheards, and then came the gold standard, Goldman applanation tonometer. So after that, advancement still continues. We have DCT, eye care, NCT, ocular response analyzer. But the problem is, with the increasing number of glaucoma patients in the outpatient department, we need a tool which is fast, accurate, and it is convenient to use. So we came with eye care and NCT. They are a very good screening tool. But the problem is their accuracy in measurement and how we can use it for managing glaucoma. Now, we need a device which is handheld, slit lamp, not slit lamp mounted, user-friendly, portable, accurate, reusable, and cost-effective. Perkins tonometer, on the other hand, it gives accuracy same as compared to Goldman applanation tonometer. And we can also use it in operation theater. But the problem with Perkins applanation tonometer is that we have to be in close proximity with the patient. That will lead to airborne infection. And if we repeatedly bend like this for the whole day, we will land up into backache. Just think about the situation where we have to do it every day. So the clinician will land up in bad health, as well as his productivity will be damaged. So we came up with an idea where we propose attaching a camera to the Perkins, enabling real-time visualization on the device, thus eliminating bending as well as lowering the airborne risk. Just think about COVID situation when we had to deal with so much. So this is the camera. The camera is HD high definition camera. It is connected with Bluetooth and Wi-Fi. It is lightweight, small and compact, and it is cost effective. It is a one-time purchase of 700 rupees. So this camera will go and fit behind the biprism of the Perkins and will attach with the help of two rubber bands. So we divided it into two steps. First, we attach the camera to the Perkins, like it is shown in the video. And then we relay the connect the camera to the screen after downloading the HD Wi-Fi CamPro app with the help of Bluetooth and Wi-Fi. So this is how it works. I stand straight, place the Perkins gently over the eye of the patient. My eyes will be on the screen, and see how beautifully the Mayas are visible. So it's that easy to learn that our sisters are helping us when it's a busy OPD. Our sisters are also helping with this. And we are using it on a daily basis right now. I'm telling with the accuracy, it is cost effective as a single tip of eye care costs 100 rupees, which should be changed, ideally should be changed. Whereas a camera is a one-time purchase and it costs only 700 rupees, and the bunch of rubber band hardly costs 2 rupees. So I would like to summarize by saying it's faster, accurate, cost effective and user friendly. Both Perkins and camera is rechargeable, so maintenance is easy. It enables real-time measurement, so it can be used in operation theater as well as in teleophthalmology. And we are using it in pediatric patient in examination under anesthesia nowadays. And it has a very short learning curve, so teaching and learning becomes easy. So I would like to end here by saying all things are difficult before they are easy. Thank you so much.
Yes, very nice.
Excellent innovation of ideas. Two things I will like to ask you. Yes. One, the sterility factor. You use it in I think, a lot of
Dr. Neha Dholakia presents the IOL cutting tip.
Each cases. And secondly, have you checked is there any error? For example, you do it with Perkins, yes, and you do it with a camera. Yeah. Have you done a study comparative there is those statistical significant difference in the reading? Maybe so the readings are different because it's differently magnified, differently something like that.
Yes, sir. So we have checked before starting with this idea. We have checked after using the Perkins. We have checked with Goldman applanation tonometer, and moreover, the results were approximately same.
I'm talking about taking with a Perkins and with a camera.
No, sir.
50 cases each.
We did not do that. We did not do that. But the only thing is, we compared it with Goldman applanation tonometry. Once I did it in one different hall, and then some other doctor did the same thing. I did not tell the other doctor what was the intraocular pressure.
Perkins is basically based on applanation.
Yes, sir.
I'm talking with camera and without
no,
camera.
Sir.
Is there any difference?
No, sir. We did not check that. We did not check that, number one. And number two, about the sterility. Yes, we sterile every time, just like Goldman applanation tonometer, we sterile it every time. The prism is sterile every time whenever we are using it on some other patient.
Because if you are using for 50 patient at
Sterility is maintained, sir. Sterility is definitely maintained. Sir, initially when we started while teaching, it consumed a lot of time, like we have to stand. But with time, like once the learning curve has reached, then it's not taking much time. Just the time of attaching.
It can't be more delayed than an applanation.
No,
Very
sir.
easy.
No, ma'am.
Very easy.
It's
Is,
easy.
is there any issue with the tremors when they're using it?
Sir, it's based on the learning curve. Like if you are able to do Perkins, you'll be able to do it attached to the camera also. It's a very lightweight camera.
I know.
It does not have any extra weight. So it can, if you are able to use Perkins, you will be definitely able to use this one also attached to it. So
No, I think it's a very useful commodity. Very thoughtfully done. We shall now go on. Thank you. Thank you. And Dr. Srustagi? Oh, you have. Yes. Neha. Thank you. Thank you. Anahita, come. Dr. Rustagi?
After that.
Oh, you have not finished. Yeah. Sorry. Oh, after this. Yeah. So we shall now go on to our next speaker, Dr. Neha Dolakia, who is going to be presenting a novel ultrasonic intraocular lens cutting tip and IOL holding forceps. On to you.
Play kar. Please play.
Dr. Neha Dolakia presents the IOL cutting tip and forceps. Broken IOL complications have been the most dreaded for years. We've been using techniques that are tedious and traumatic to the wound and the endothelium. The snare technique, which cuts the IOL into two halves, the twist and out technique, which requires a swift and skilled surgeon and can stretch the incision if not performed properly. IOL explantation through a cartridge, which needs force and can stretch the wound out. Crocodile scissors, which are bulky and cause rocking of the IOL and endothelial damage, and thereby getting post-operative striate keratitis and even a Descemet's detachment at some time. Introducing this innovative tip, which makes it easy for any surgeon to cut the IOL extremely easily into 3 or even 4 or even 5 parts. Each sliver is only 2 millimeters in width and hence can be removed easily and gently through a 2.2 millimeter incision without stretching the wound or extending the wound at all. The reasons for explantation are broken haptics at the time of insertion of the IOL, an unhappy patient due to halos and glare, especially in ringed IOLs, refractive surprises, dislocation or subluxation of the IOL. Now the tip is a stainless steel tip which is designed after many attempts to get the length, breadth, angle and sharpness right. The phaco probe has to be primed just as usual with the normal tip, and then the tip is removed and the IOL cutting tip is screwed in and tightened, and then over it the sleeve has to be attached. The forceps are such that the jaws of the forceps open and close vertically just like the mouth of a crocodile, but the grip is such that it is horizontal and open and close parallel to the ground between the thumb and the middle or the index finger. It is ergonomically designed for ease of use. The surgeon introduces the forceps through the side port and gets a good bite of the IOL. Then the surgeon positions the tip and simply presses on the foot pedal. The vacuum and aspiration are at 0, irrigation is on but low, power is between 20 to 50, that allows us to cut any hydrophobic or hydrophilic IOL with ease. As you can see here, the IOL is cut just like butter, so easily within 1 second. And the pieces can then be removed through the incision without extending the wound. This is an in vivo demonstration of the same. The IOL is being cut into slivers of 2 millimeters each, and each sliver can be removed without stretching the wound. The pieces have to be aligned parallel to the incision such that each piece can be removed efficiently without damaging any part of the eye. Advantages over the other techniques. can easily explant the IOL without extending the wound at all. There is no tilting of the IOL like with the scissors. There is no stretching of the wound. No special surgeon skills required. One can cut the IOL into even thinner slivers if the need be. All in all, this technique uses the ultrasonic power of the phaco machine and removes the IOL, respecting the posterior capsule, the wound, and most importantly, the endothelium. Thank you very much.
That was
Thank you.
wonderful. I would ask Dr. Ellen Kumaran to take the question.
Ma'am, that was a very good
The next speaker
video.
is Vignesh.
But my questions now, many people are using it, I presume, right
Yes,
now.
yes.
What about the complications that have been noted?
So touchwood, till now I have got videos from so many doctors. This was made before. I have that video with other. Nobody is getting SK the next day. Everybody is getting 6/6 vision. I'm getting a call almost every second day from some part of India. Thank you so much. It was extremely good. Yesterday, Dr. Ashish Vaidya from
Dr.
Bombay
Neha
called.
Dholaki.
Volume off रखिए उसमें. So I have some videos of that also.
No, ma'am.
Yeah.
That's okay.
With them showing the post-op and everything.
Okay.
And also the hardened IOLs, which are opacified, they are very difficult to cut with the scissors.
Yeah.
This actually strangely cuts that more easily. Maybe.
And the chamber is
But the
maintained.
hardened IOLs, opacified IOLs are largely hydrophilic IOLs.
Yes, yes.
So they can actually be removed easily without enlarging the incision.
Correct.
So
No, but when I think when a hydrophilic IOL is to be removed normally,
Yeah.
it's easy. But when it gets opacified, it becomes little stiffer. That's
Yeah.
what everybody else is removed, because I just made the innovation and removed one IOL. Then everybody
Yeah.
else has done that. Hard PMMA, no, sir, no. And it can be attached to any phaco machine. And
what is the
used.
parameter you set on it?
So vacuum 0, aspiration 0, irrigation flow on, and we've been able to cut IOLs with 20% power. So 20% power in the anterior chamber for like 3 seconds, it doesn't cause any
Yeah.
damage.
Cost of tip?
No, I have tried other techniques, but I think the scissors opening and closing, which are the Packard. Endothelial count, I think vision next day is 6/6 crystal clear cornea. Huh. Scientifically not counted endothelial count, sir. Yes.
Thank you, Neha.
you.
We should go on to our next
Okay,
speaker.
yes.
Thank you. So let's hope Anamika does not. Anahita does not have any glitch this time. So on to you for our Insight VR IOL stimulator.
Cataract. In spite of all the advancements in ophthalmology, cataract remains the leading cause of blindness in the world. From its first ever surgery done in the 1700s, it's increased in popularity and now it is the most common surgery being performed in the world. The market has a dizzying array of options available for the intraocular lenses. In most high volume hospitals, the doctor advises the patient cataract surgery, but the counseling part is usually taken care by the designated counseling professionals. Will attempt to explain the features of different types of IOLs available using the aids of pamphlets and charts. This information overload can be overwhelming for the patients, frequently leaving them confused and indecisive. Presenting our solution, Insight. Our engineers work day and night on a software called Unity to make 2 immersive virtual reality scenarios. 3 reference points are kept to emulate near, intermediate and distance vision, and we modify them to simulate vision with different IOLs. For example, here we show vision with monofocal, bifocal, multifocal and EDOF lenses. Similarly, our outdoor scene recreates vision with cataract, monofocal, bifocal, multifocal in day as well as night and EDOF lenses. Not only the focal points but also the contrast and saturations have been altered to simulate accurate view of the surroundings. For example, in multifocal light you can see the halos and glare that is expected. This might appear very futuristic, but all you need is a VR headset which you can get for as low as 400 rupees, or one can also download the free for all Google Cardboard PDF to build cost-effective homemade VR goggles. To test out our product, we conducted a small survey wherein we asked a variety of people to try the VR experience and give their honest reviews. We showed it to doctors, MLOPs, PGs, and also one patient and his attenders. And to our delight, here is the feedback we received from them. All the participants felt that insight would be beneficial for the patients and ease their decision making process. We asked experts if insight somewhat correctly emulates post op vision, and 83% of them concurred. More than 80% people agreed that insight would make the counseling process easier and smoother. We can keep one in all the counseling cubicles, as all you need is a VR goggles and any regular Android phone to run the free app. About 95% people felt that patients are more prone to choose premium IOLs once they better understand the details using Insight. Most of our participants also felt that this would help address post-op dissatisfaction by providing realistic expectations.
Before sir, we are showing how will be the feeling and everything. So the patient knows it.
After receiving such a positive response, we conducted a pilot in how to use and implement Insight. The Insight VR experience was shown to all the patients who were advised cataract surgery, and it was very well received. The advantages of Insight is that it is a cost-effective solution which is freely available to all. It is easy and it provides a realistic experience to doctors, sisters, patients and their attenders. There are multiple advances possible, for example to mimic vision with other diseases like glaucoma, adding more scenarios and the ability to move inside the scenarios.
Thank you, Dr. Anahita. Thank you. Very useful gadget. Question?
You can show, please.
This is the app. So I have different apps for multiple scenarios, and if we put it in the VR headset, it transforms us into a scene which we feel we are actually in there. So it's an immersive thing, and this is like a generic for all the IOLs. It's not a particular like Synergy or AuroView, but generic like monofocal. What we tell the patients, you won't be able to see near intermediate, but distance will be clear. And multifocal, you'll be able to see all ranges with clarity, but there will be a slight lack in contrast, and there'll be halos at night. So we have tried all the positive as well as negative aspects of all the IOLs, so that the patients can have a better decision making experience.
I think it is of great importance, and I think all of you know, and ma'am especially must be knowing, a famous celebrity went for a VVT lens and he had a lot of problems with that IOL and all. So I think if you have this inside VR, I think patient is much more convinced.
Yeah, it is.
My question is only how to, adults can understand, but what about pediatric age group or means slightly less than 14 who are not that mature enough?
So like
how to tackle these people?
So less than parents have to decide, and
but parents cannot see through it, no? Okay.
So
yeah, even the kids are using. The kids are also using the VR headsets. In fact, a lot of immersive gaming nowadays is these headsets.
So even you can.
And
no, the patient's father.
Only the father would be able to see, and
he will fit it on his head and see. Good.
Doesn't matter.
This is the multifocal at night, sir. You see cars and windows, but the letters and other.
I think there were other I think Alcon also had something like
Dr.
this
Vignesh?
in its arsenal. Now they've made it freely available through open source. So I think it's a very nice advancement as well as an innovation.
Dr. Anahita? Dr. Neha,
please.
Neha, come and take your, just 1 minute. Neha.
Congratulations, Dr. Neha.
Congratulations, Neha. Anahita, come. We have just 2 more speakers we have. Yeah. We go on to our next speaker, Dr. Vignesh, who's going to talk on Crabtree effect as a parallel pathognomic pathway in diabetic retinopathy. On to you.
Good morning, everyone. So today, my topic is Crabtree effect and how it can be used for a proposed novel strategy for diabetic retinopathy. So we all know that a proven causative factor for diabetic retinopathy is hyperglycemia and poor systemic glycemic control. Multiple proposed theories exist, but none have been proven to have any treatment strategy as such as of date. So just a short recap about the glucose metabolism. Glucose proceeds through glycolysis to form pyruvate. From onwards, it can have two end results. Either in anaerobic condition, it can become lactate, or in a presence of oxygen, it can go on to acetyl-CoA, Krebs cycle, and oxidative phosphorylation. So what happens in hyperglycemia? There is a preferential conversion of glucose to lactate. This is called the Crabtree effect. So this phenomenon has been demonstrated in retinal cells, and it can be postulated that in diabetics in hyperglycemic states, retinal cells may chronically overproduce lactate from glucose metabolism. So what can this lactate do? There is evidence to show that increased lactate can stop the ubiquitination of HIF-1 alpha. So causing overexpression of HIF-1 alpha. This HIF-1 alpha will translocate to the nucleus and cause production of VEGF. And VEGF, as we all know, causes neovascularization and increased vascular permeability, leading to the stages of diabetic retinopathy like PDR and DME. So how do we control this? This lactate has an efflux transporter called monocarboxylate transporter, which can be inhibited to increase lactate concentration inside the cell. This lactate will then get converted back to pyruvate, and by inhibiting the enzyme called pyruvate dehydrogenase kinase, we can force the glucose metabolism down through acetyl-CoA and then to Krebs cycle and oxidative phosphorylation. So what will this do? When there is there's not much increased lactate concentration, the ubiquitination of HIF-1 alpha will proceed as usual, and there will not be any VEGF release. Thus, it will cause regression of the pre-existing diabetic retinopathy lesions. So these are some of the drugs which are available, like in preclinical and clinical studies: dichloroacetate, AZD3965, AZD7545, which can be utilized to cause regression of these diabetic retinopathy lesions. So how do you prove this hypothesis? Initially by cell studies using vascular endothelial cells, then animal studies using DR models, subsequently proceeding to human studies. A possible similar pathogenic pathway for diabetic nephropathy has also been postulated. So it is possible that systemic administration of these drugs could possibly prevent this and help reverse diabetic retinopathy and nephropathy as well. Conclusions. So Crabtree effect and lactate is a possible DR alternative pathway. Targeting this pathway could lead to regression of diabetic retinopathy lesions. There are drugs available in preclinical trials for other indications which are available to target this pathway. Drug repurposing is cheaper and can be checked in diabetics to look for DR regression, and it will have an instant widespread impact as the burden of vision loss due to diabetic retinopathy is well known. And if proven, potential instant applicability worldwide in all diabetic retinopathy patients. Thank you.
Very nice concept, but how you can implement in patients
Sir,
without trials? And also, what are the side effects? Because this is not meant for diabetic retinopathy as such.
Yes, sir.
Yeah.
So initially we'll have to try out in cell line studies and animal trials using diabetic retinopathy models before we can proceed to human trials, sir.
So still it is in the pipeline.
Yes, sir.
It's only a theoretical concept.
Yes, sir.
So right now it is bench, it's not bedside.
Yes, sir. Yes.
And even in bench, it's more at the level of cell lines than at animal studies.
Yes, sir. Yes, sir.
Okay.
Thank you. Thank you very much. Our next speaker is Dr. Anita Kumari. Is Anita Kumari there? Dr. Mukesh? Dr. Mukesh Dholakia and Dr. Anita Kumari, both are not there. Okay. So I think maybe we have the time. If all the speakers in the session are there, along with the judges, we can have a photograph taken. It is a self-indulgence moment. So all the speakers, could you please come up to the stage? Come.
We will document your nightmare for you. Come.
Come and stand here. I think उधर आने बोल रहे हैं। बैकड्रॉप दिख रहा है।
बैकड्रॉप इज इम्पोर्टेंट। वैसे तो मैम के साथ बहुत सारा फोटो खींच रखे हैं ना सभी लोग।